This is, I call this part 2. I gave part 1 back at RDIM at the beach about 18 months ago, and we talked about a number of guidelines and research articles that had come out since the release of JNC VII in preparation for the release of JNC VIII. When I signed up for Grand Rounds this year, I did it in April, fully expecting that this was going to be a talk about JNC VIII. However, JNC VIII is still yet to be released. And so I had to come up with something a little bit different. And so I took a look at some data that has come out since my last talk, and then wanted also to focus on a couple of different areas that I didn't focus on last time. Okay. How do we make it go forward? Sorry. Okay, so the obligatory conflict slide. I'm an investigator in the NIH Sprint trial. Great to see some of the greatest research staff in the world back there in the back. Hopefully they didn't bring anything to throw at me. And then really that's my only major conflict. And so in part 1, just so you know where we went, so you didn't think I just picked things out of a hat, although I probably did, wanted to talk a little bit about what we did last time. And so last time, we reviewed a number of specific trials that could affect the guidelines produced in JNC VIII. MARPLE, which was a study that showed a lot of data regarding the risk of having proteinuria or albuminuria in the setting of hypertension and adverse outcomes. Talked about On Target, which was an attempt by telmisartan to redo the HOPE trial, and while they did that, also to go head-to-head against ramipril. It turned out that they provided a couple of interesting pieces of data in that they weren't better than ramipril head-to-head. And we also learned from that when you combine an ACE and an ARB together, really the only value that you get is improvement in microalbuminuria or proteinuria and nothing else. In fact, there are more risks with hyperkalemia and other events from that. ACCOMPLISH, which was a head-to-head trial basically of hydrochlorothiazide and amlodipine in the setting of patients on benazepril therapy. It's a trial we'll talk about a little bit later, but it was stopped early because amlodipine flat smoked hydrochlorothiazide, and they stopped it early because of outcomes. HYVET, which was one of the more important trials that validated the treatment of hypertension in those that are in the elderly. So that also talks a little bit about some of the guidelines that we talked about there. For the house staff, you know, we talk about the American Society of Hypertension guidelines in treating hypertension and diabetes. It's a very valuable document and has very straightforward recommendations. And then also in that talk, we also looked at some of the older medications that we use. So for this, let's talk a little bit more about CKD and or proteinuria. Many people would say they're essentially one and the same. Heart disease. And the reason why we want to talk about heart disease is because in the SPRINT trial, interestingly enough, we have 2 targets. We have a target that's a systolic less than 140 and a systolic that's less than 120. And so the patients with heart disease that are in that trial, many of the cardiologists will give pushback for the target where we're trying to run people at 135 to 140 because they say their guidelines dictate that we should be treating people to a lower target. So we'll review a little bit of that data. Also review some data about older age and diabetes. And then also, one more time, with some new data this time, talk a little bit about hydrochlorothiazide versus chlorthalidone. So let's take a walk back in history. JNC VII Express was released in December of 2003. If you take a look do a Medline search at everything that says hypertension since then, there's a grand total of over 125,000 articles that you could find, and no, I did not read them all. And so over 22,000 of those are listed as review articles. Interesting events in history that have occurred since then are that Part D for Medicare came out in January of 2006, and the $4 plan for Walmart came out a few months later. So those are now right at either a little more or a little less than 7 years old. So we've been using those for a while, and we've been fighting those battles for a while. So let's start out for a moment talking about when should we take our medicines. So the house staff over the last few years have been actively involved in a program called IPIP, which is Improving Performance in Practice. So it is an opportunity for them to work on quality improvement. And so in that work on quality improvement, one of the areas that we focus on is with diabetes because, let's face it, we see a lot of diabetics. And we all can be better at the management of diabetics. So every year we take the opportunity to look at the ADA Standards of Medical Care in Diabetes. And so if you look at this year's version and you go to the section on hypertension, hidden away we see a couple lines. Administer one or more antihypertensive medications at bedtime. And lo and behold, when you look at that, it's got grade A evidence. So what I wanted to do was evaluate that trial that was listed that made this grade A evidence. So this is the MAPEC study. And so this came out in Diabetes Care in 2011. And so if you look at this, there's only 448 hypertensive patients with diabetes that were included in this trial. So it's a small number. However, they did a very simple but elegant procedure, although my saying the word elegant, well, you make your own joke. So they were randomized to ingest all of their antihypertensives first thing in the morning or to take one or more at bedtime. So it's a very simple strategy. Their outcomes that they reviewed in this were all cardiovascular outcomes and then also stroke and other events that are there. So if you look at it, they follow these patients up for a median of over 5 years. And when you look at the two groups, there were no differences in classes or number of meds that were used between the two groups. Quite frankly, they were very similar populations, and one group took at least one medication at bedtime, the other group took everything in the morning. So if you look at the areas that are highlighted in bold there, you'll see a couple of interesting pieces of data. One is the proportion of patients with a controlled blood pressure, and they did interval ambulatory blood pressure monitoring studies on these patients throughout the trial. And the proportion of those who were controlled by that were significantly greater in those who dosed their meds at bedtime. Also, the bedtime dosing group had fewer non-dippers. And so if you'll recall, that we're not talking about tobacco abuse here. What we're talking about is the definition of a non-dipper is those whose sleep time systolic decreases less than 10%. All you guys that work at night, you get a call about 3 a.m. and Sally Smith's blood pressure is 90/60. And you ask, well, what's she doing? She's sleeping. Let her sleep. And so the normal physiology of that is that our blood pressure should drop overnight. However, there are groups of people where this does not take place. One of the more important groups where you see this is those patients who have obstructive sleep apnea. Also, if you look at those of African descent, you will also see a higher percentage of non-dippers in those, and there's been some effort to try to evaluate that a little bit better and to see what we can do about that. So, as you move forward, again, the positive p-values there are in bold. And so what you'll see is the bedtime dosing group had significantly lower mean asleep blood pressure than those who dose their meds usually or dose their meds in the morning. Although the difference in clinic and awake blood pressure readings were both small and insignificant. So let's think about this. The only real difference when you looked at the numbers in these folks was their asleep blood pressures, not at any other time. So if you want to look a little bit more at events and outcomes, which is why we do these, is to try to help people do better, is you see that the bedtime dosing group had a statistically significant difference in event-free survival in both total and major cardiovascular events. So think about this for a moment. All they did was give one or more of their antihypertensives at bedtime, and they had an improvement in outcomes. So this is nice. Also, what they found, there's some people in this room generally who sit over here who have a discussion about something called a J-curve. And what they found was there was no J-curve with achieved sleeping blood pressure, but there was with the achieved awake and clinic blood pressures. This next slide is a bar graph to show this a little bit better. And so what you see for the top is the achieved asleep systolic blood pressure. You just see the curves continue to go down. Whereas the achieved clinic systolic blood pressure, once you get down, this is a 134.3. Once you get down to this systolic number, you begin to see the curve that goes back up. Therein, the J-curve. So, what you found there was an opportunity to do something that was very simple that makes the argument that what we should do is dose at least one or more of our antihypertensives at bedtime in our diabetics. And on the basis of this is something that we're going to need to reevaluate and discuss in our clinics and to be able to move that going forward. Next, let's talk about the KDIGO guidelines. Yes, I know there's a bunch of nephrologists in here, but I'm going to talk about them anyway. And so these are the KDIGO guidelines. As you guys know, my 4-year-old's Katie, otherwise known as the Beast. And the Beast is always on the go, so I tend to call these the KDIGO guidelines. So the KDIGO guidelines, or the KDIGO guidelines, updated blood pressure management in patients with kidney disease. Now, they talked about a number of different areas, including transplants and peds, but we won't talk about that. Let's talk more about those patients with and without diabetes, and a little bit of discussion in those in the elderly. So, if you look at what they said and you looked at their targets, they did something that's a little bit different. They based their targets solely for those with CKD on albuminuria. For those of you who are in clinic on a regular basis, what you know is something that we did some time back, because we know that microalbuminuria and proteinuria are significant risk factors for cardiovascular disease in those with hypertension as well as those with diabetes. We began having all of our patients with hypertension undergo a yearly microalbumin. And what we're going to institute in the very near future is we've been working on a set of guidelines for the management of that, not just to check it, but what do we do about it when we see it? And those are going to be coming out for our clinics in the near future. So if you look at those who have CKD and have no albuminuria, their target is less than 140/90. However, if you have even modest albuminuria or macroalbuminuria, what your goal will then be less than or equal to 130/80. And the agents that we should be using for them are ACEs or ARBs. Also, what they did was something that I believe is very important. In some of their discussions, they put in there the multiple different ways that multiple different clinics will evaluate this, and they gave you more of a comparison slide in there so that you could take the way you do it and help to have a better understanding of into what group these patients will fall. For us, what we do in clinic is we have a point of care test where you come back as less than 30, 30 to 300, or greater than 300. Other clinics will do different things. From that greater than 300, admittedly, there's more work that needs to be done. In those who are 30 to 300, there's more work that needs to be done. So, often what you will have when a large set of guidelines will come out, prior to that, you will begin to see the reviews of the evidence that shape those guidelines. And you saw the review of the evidence in the annals about 2 years ago. So what they did was they reviewed trials with a handful of requirements. Blood pressure targets in adults with CKD greater than 50 patients per group. They needed to have at least 1 year of follow-up, and they needed to have specified outcomes affecting cardiovascular events and renal events. So, for all the trials that have been done, when you use that criteria, there's a grand total of 3 trials that they were able to say fell into this. And not only were there 3 trials, there were 3 trials that were very different. So for this is a reminder to fill out your evaluation forms, including the quality of the slides, including those that don't always project well. I put this in here more as a reminder for me to be able to say, if you look at the groups, if you look at the ASH trial, 100% black. The MDRD trial, almost 100% white. Not only that, is the inclusions and exclusions for these trials were different on the basis of GFR and different on the basis of proteinuria. So you have 3 somewhat disparate trials for which they are trying to use to make new guidelines. So if you think about that, one of the issues is that we need more patients, we need more trials to be able to have more data. There is an arm for CKD and SPRINT, and I don't want to get in trouble for too much bias, and so I won't talk about it too much, but there is an arm there, and hopefully by about 2018, we'll have a new data set that we will be able to use to help us in making our goals and our guidelines. So, if you look at this article, what they said was this: there is no definitive proof that a blood pressure target of less than 130/80 improved outcomes more than a target of less than 140/90 in adults with CKD. However, they said lower quality evidence suggests that the lower target may be beneficial in those who have some proteinuria. They admitted that no articles in the review examined blood pressure targets exclusively in those with diabetes and chronic kidney disease. Again, another opportunity for further study. So the lower quality evidence includes a number of studies that you may or may not heard of. The ASH trial had a follow-up study that came after it. Case J was using candesartan. The HOPE trial is one of the classic medicine studies. It's one that I tend to be able to remember and to be able to quote. It's a trial that uses ramipril, and then you see a number of other studies that are there as well. So next, let's talk for a little while about coronary artery disease. And when we talk about this, we're going to talk about blood pressure goals in those patients who have it. 2007 in Circulation, there was a pretty significant guideline statement that came out about this. A number of groups weighed in, a number of groups were able to comment on it, and in those groups, again, there were multiple disparate voices, and this was more of an expert consensus guidelines in their opinion, but the guidelines were given. So, if you look at their recommendations, they gave a target for those with CAD for less than 130/80, for diabetes, chronic renal disease, and then a number of different cases of cardiovascular disease. Also, interestingly enough, what they put in there was if you had a 10-year Framingham risk of 10%, you should be driven towards a lower target. Well, if you look at the International Society of Hypertension in Blacks and their guidelines, they're another group of folks who actually use that Framingham risk to shape the targets and where you need to be with your blood pressure. So I thought it was interesting that they put that in there. So if you look at these two groups with CAD, on the far side, you have Eastern North Carolina. On the near side, you have everybody outside of Eastern North Carolina. So for our patients, you could make the argument that most folks need to be less than 130/80. However, after they made these guidelines, they qualified them somewhat. And they said there are no clinical trials specifically designed to answer the question about the appropriate blood pressure targets in those with latent or overt CAD. So they based their data on epidemiologic and other studies. Again, there are further studies that are coming out. There are a number of patients with CAD that are in the SPRINT trial. That's one of them. There's some new trials that are going to be coming out sooner than ours will that are going to talk about this as well. So, if you look at some of the trials that drove this, I want to just mention for a moment the CAMELOT study, and this is a setup to go to what I really want to talk about. So CAMELOT was a double-blind, randomized, 24-month trial that had about 2,000 patients who had coronary artery disease, and their coronary disease was diagnosed a variety of different ways, including angiographically. Now, it was used to look at amlodipine and enalapril versus placebo. However, what I really want you to see is if you notice the baseline blood pressure of the patients in this trial was only 129/78. These are patients with good blood pressures, okay? Now, that was the initial study. However, what they did was they took 274 patients and they put them also in an IVUS sub-study. And so what they did then was they found a long vessel that had coronary disease and they evaluated it with IVUS. They repeated that same IVUS 24 months later. And then they evaluated these patients according to their blood pressures. So if you look at those patients who had a blood pressure of less than 120/80, and you looked at the atheroma volume on IVUS on follow-up, it actually decreased in size. However, if you look at the patients who were 120 to 139, kind of more in line with current targets, then you saw a very modest increase in the size of the atheroma volume. Finally, when you see those patients who are greater than 140/90, you see a significant increase in the size of the atheroma volume. So one could argue from looking at this data that when you have patients with coronary disease and a blood pressure greater than 140/90, there is something that's going on that's causing them to have more and more plaque that's growing there. So let's look at INVEST. INVEST, as you see the dates, is an older trial. However, what you see in a number of these very large trials is that over time they will go back and print paper after paper after paper after paper, looking at multiple different sub-studies and looking at multiple different groups. So this was randomized and open label. So this is a cardiology study, and cardiologists do it right. 22,576 patients. So they got a lot of folks in there, and they all have coronary disease age greater than 50. And the coronary disease was diagnosed by a variety of different methods. Multiple sites, multiple countries. And so what they did in this trial was basically challenge the dogma of the time, saying that if you had coronary disease, we always give everybody beta blockers. So they challenged that and they said, we're going to compare atenolol versus the use of verapamil in these patients. So is this trial applicable to us? Well, prior smokers about half, so we're there. Diabetes about a quarter, well, we see a few more of those. Patients in this study with chronic renal disease, a miserable total, and then a very modest total of patients who have congestive heart failure. So the primary outcome here were a number of different cardiovascular events. They also looked at blood pressure control and hospitalizations. Keep in mind, this study came out in 2003, about the same time JNC VII was released. Therefore, they used JNC VI goals. So for those who had diabetes or renal impairment, your goal was less than 130/85. And for all others, the goal was less than 140/90. I show you how they did this because I'm going to make a point in a couple minutes. The calcium antagonist strategy is verapamil, and they started everybody there. In the atenolol arm, they started folks on atenolol. If you needed an ACE inhibitor, if you had an indication for an ACE, you got an ACE. So good. So then as you walk down to step 3 in bold, what you find is they did something very interesting. They chose is they increased therapy for patients who were not at goal. They dosed their atenolol twice a day. So we're going to come back to that. And then they continued to drive through to be able to get people to their targets. So if you look at the data in all of this, at the end of it, patients in the verapamil group pretty much ended up on verapamil. Patients in the atenolol group pretty much ended up on atenolol. More patients were on an ACE. I think a lot of that was probably due to the way that the protocol was done. But if you look at the primary outcome, there's really no difference. If you look at blood pressure control, there's really no difference. In bold, what I put was something that I found very interesting. If you look at the patients who developed diabetes during the trial, more of them were in the atenolol group. Now, we know this from other trials that beta blockers tend towards diabetes, but here's another trial that showed that. And again, I say that now because I'm going to say something in a minute. So, we begin over the last couple years with the subgroup data that begins to come rolling out. This is Invest Revisited. So what they noted was what we just saw. There's a higher rate of development of diabetes in the atenolol group versus the verapamil group. But here's the thing. When they looked at these patients 5 years later, the rate of all-cause death in those who developed diabetes was the same as those who were diabetic at entry into the trial. So let's say that one more time. If you were diagnosed with diabetes during this trial, your all-cause death was the same as if you came into the trial with a diagnosis of diabetes. So I would argue that that's very important, because if you're using medications for which you're going to have more folks who are diagnosed with diabetes, then you're going to end up driving more folks to outcomes. Now, I'm not talking out of both sides of my mouth when it comes to chlorthalidone, because you've seen some signal with chlorthalidone in this, but you didn't see some of the changes in the outcomes data that went along with it. So, they also noted something that was very important. They noted that the atenolol group, and all those patients in the atenolol group where atenolol was dosed twice a day, it was not associated with an increased risk of stroke or other cardiovascular outcomes. Let's compare this with the LIFE trial. If you'll recall, LIFE trial is the one that sometimes I will say was the last nail in the coffin for the use of beta blockers as primary therapy for hypertension. What it was a trial in which you had a strategy for losartan, Cozar, versus atenolol. And when you followed these patients over time, the curves for stroke diverged early and stayed diverged throughout. So how in the devil can you use a drug first line when you have another drug that flat out smokes it when it comes to stroke? And so, but what you see here is the patients in this trial who had coronary disease, if you gave them their atenolol twice a day, you did not see that. Therefore, we can make the argument that atenolol perhaps should be dosed twice a day in those patients who need it. And I think that's something that we need to continue to consider. Also, what they found, it's always good when clinical trials give some proof to good old-fashioned common sense. So the proportion of visits in which patients were in control were predictive of the risk of reaching the primary outcome. So next we'll show this for those who like bar graphs. All the way on the far side is those patients who less than a quarter of the time came to their visits and they were at goal. And so if you look at that arm compared to all of those who even the meager amount of visits that were a little bit more than a quarter of the time they came at goal, they had statistically significantly fewer events than those who you could never find that were in control. For those of you who don't like bar graphs and who like a different version of the way of evaluating this and looking at this data, this is just a different way of discussing it. However, I'm going to draw your attention to that which is found at the bottom. And those are the stroke curves. And this is some signal that has continued to play out over the last few years. If you look for those patients in the stroke group, for those who had more and more percentage of visits where their blood pressure was at goal and controlled, they had fewer strokes. And so if you look at some other data that's come out when you talk about lower blood pressures and hitting targets, I think you've seen the same thing. So they also found, here we go again, the relationship between the primary outcome and follow-up blood pressure once they were adjusted for their baseline differences, followed a J-curve. Interestingly enough, the nadir of this J-curve was 130/74. Also what they found was about 11% of the patients in this study had a diastolic less than or equal to 70. However, this 11% of patients accounted for 20% of the primary outcome events. Certainly that raises a question as we drive the diastolics lower and lower. Are we driving them too low and leading to events? So the next sub-study that we'll look at here is looking at those by age. So what they did is they went back and they took the INVEST patients and they divided them into 4 different groups. What you'll see is the greater than or equal to 80-year-old crowd had 2,180 patients. HIVET, which is considered one of the major trials looking at the control of blood pressure in the elderly, only had 3,800 patients. And so SPRINT has a senior group for those older than 75, and I haven't looked at the data to go back through recently, but 2,180 sure looks like a big number to me. So if you look at that, about a quarter of the patients greater than or equal to 80 reached the primary outcome. And then when they followed up blood pressures at 2 years, those greater than or equal to 80 had the largest drop in systolic, the smallest drop in diastolic. Therefore, you had the largest increase in pulse pressure. So over time, pulse pressure continues to be a phrase that we, and an issue and a parameter that we continue to follow, because the more we see it and the more we look at it, the more it raises questions on, is this a driver in people that have older and calcified and nasty old blood vessels? So they also found that the relationship between blood pressure and outcomes followed a J-curve, but this J-curve was very different because it differed by age. So the orange triangles are those who are greater than or equal to 80. And so if you see this group here, and it's interesting, they put the diastolic further away and they put the systolic closer to us. I always think about them the other way. But if you look at this, you'll see the 80-year-old group, turns here at about a systolic of 140 and turns back upward, whereas the younger crowd, the less than 60, their curve it starts to flatten, but it never really makes much of a turn until you can make a guess, and guesses don't do well in evidence-based medicine, that down here around 110, you're beginning to see that curve flatten out. The diastolic curves, though, are different as well. And so here's the 80-year-old group, and it loops around, and you see that its nadir is somewhere here around the high 70s, low 80s. And then you see other groups that really make the turn back up. So you see very different J-shaped curves according to blood pressures, according to age. So, yeah, I know there are too many words on this, but I wanted y'all to be able to read it the whole way through, because this isn't a statement that you really want to paraphrase, but I'll try to summarize it briefly. It's very simple. This goes back to these same guidelines for patients with heart disease. If you've got somebody who got heart disease and evidence of ischemia, common sense again, as you try to decrease their blood pressures, do it slowly, do it cautiously, and really take your time. Then, once you get diastolics down to around 60, you should really have some concern there, especially if they have diabetes or over the age of 60. So also remember that the pulse pressure changes and increases over age, and so as you try to make attempts to drop the systolic, then you may also cause patients to have very low diastolic values. It is something that we've been seeing in some of the patients that we follow. As we try to drive a systolic towards a goal, that diastolic begins to get a little bit too low for some of us, and while the patient's blood pressures don't come down very well, my blood pressure goes up, and I know Connie's does, and I know Dr. Chung's does, and so a lot of our blood pressures begin to rise with these people when they come in and they have the I don't feel wells. So also remember that in the very old, those over 80 years of age, antihypertensive therapy is effective in reducing stroke, but you really don't see a whole lot of lowering for other coronary events. So I think this is the last study for INVEST that we're going to talk about, but we're going to come back and we're going to talk for a moment about the diabetics. So in this very large study, there were 6,400 diabetics at entry. And what they did was they divided them into 3 groups. Tight control here is a blood pressure maintained at less than 130. Usual is 130 to 140. Getting around, the tighter is what we want to do now for our diabetics. 130 to 140, a little bit higher, and then the uncontrolled greater than 140. Now, keep in mind, 3/4 of all of these groups, at least, were on a RAS blocker. So they were on the medicine they were supposed to be on. Now, this is where it gets a little iffy. They followed death registries. That strikes me as an opportunity to miss some events. So what they did here again is when you look at this, you see a number of different positive p-values. But what's really important here is if you look at the events for the primary outcome, so in the tight control, remember, less than 130, then you see about 13% event rate. 130 to 140, what you see again, about a 13% event rate. You get greater than 140, then what you see is the event rate is right at 20%. So you see higher rates for those who have blood pressures consistently greater than 140 in the setting of diabetes. You see the same for all-cause mortality, you see the same for total MI, and you see the same for total stroke. I think you can argue you're beginning to see a trend. There's something about this number 140 that there's some issue here in our diabetics. So what you see in this is for those of you who like to have your data plotted a very different way, this is the same data that's plotted in a different way. So you see the better controls groups, the less than 130 and the 130 to 140 sit real tight together, whereas the uncontrolled crowd is very much separate and off in the distance. So what we want to do now is to go back to what the residents are tired of hearing me talk about, and that's hydrochlorothiazide versus chlorthalidone. So, series of articles here. This is an article that came out a couple of years ago about hydrochlorothiazide. And the authors in this article really went to great pains to lay out a case of why they don't like it. So we'll talk about it for a minute. So, those of you who heard me say, chlorthalidone has never been beaten for outcomes in a big clinical trial. However, HCTZ has been. The accomplished trial where we talked about, where in those patients who were on benazepril, amlodipine was found to be clearly superior to hydrochlorothiazide. And then you see A and B2, and then also the reanalysis of Mr. Fitt, and we're going to come back to that in a moment. So, the arguments that the authors make here is that inferior blood pressure control at the doses that we use. So hydrochlorothiazide in its usual dose hasn't really been shown to reduce morbidity and mortality and hypertension. Not all thiazide diuretics are created equal. If you look at the NICE guidelines, they make the same argument. And then what they also show is adherence to thiazides is inferior to any other drug class, and they feel that thiazides have been inappropriately promoted. Hydrochlorothiazide is the hypertension, what metformin is the diabetes. They will put it in combination with any drug, and so they all like to run together. However, the difference between the two is metformin has great data. Hydrochlorothiazide, we can argue otherwise. So, let's look at the reanalysis of Mr. Fitt. This is a very old trial, but the data is applicable today. So, if you look at it, it's a cardiovascular primary prevention trial in about 13,000 men aged 35 to 57. It began enrolling all the way back in 1973. So, patients in this trial were randomized to a group with intervention of hypertension, smoking cessation counseling, and dietary guidance versus a group where you go to your doctor, you keep doing what you're doing, and we'll see how you do. Now, here's the issue. Initial therapy, using a thiazide-like diuretic. I don't know if any of you guys use 100 milligrams a day of hydrochlorothiazide. Don't know if any of you guys use 100 milligrams a day of chlorthalidone. They use really big doses. And the goal there was a diastolic of 89. So the primary outcome in this reanalysis was the time from which they found that any given patient was on chlorthalidone or HCTZ all the way to their first cardiovascular event. Now here's the problem with the data. Significant percentage of patients crossed over to the other group, and there was a fairly low percentage of patients who spent time in any one particular group. However, we still need to look at this data because there's still some issues that we ought to at least have discussed. Also, the two groups had some differences. So, what they found is if you on one of these two diuretics, your cardiovascular events were significantly lower than those on neither drug. Okay, so you see some data that they help. However, in March 1980, they looked and they showed that cardiovascular mortality in the clinics utilizing HCTZ was a great deal higher than other clinics. So they made the executive decision to take everybody who was on a diuretic and everybody goes on chlorthalidone. After that time, you saw the rate of mortality for cardiovascular events decreased by 28%. So for those that were on HCTZ, mortality's higher. Flip them to chlorthalidone, those curves start coming back down. So why? Well, for any of you guys that have used chlorthalidone, you know that it lowers systolic blood pressure more than HCTZ, even in a pound-for-pound analysis. So remember, every 2 milligrams of HCTZ, 1 milligram of chlorthalidone. The 25 of HCTZ is 12.5 of chlorthalidone. They talk about some differences in what chlorthalidone does to LDL and the glucose values. They also show what we also know very well, that if you're on chlorthalidone, your potassiums are going to be much lower, and you're going to spend some time going after those. So, next is a systematic review and network meta-analysis. The problem with meta-analyses is they're a lot like casseroles. You can throw a whole lot of things in there, and you don't really know what you're going to get, and you may get something different every time. However, we still need to look at this, where they looked at trials where one arm was based on hydrochlorothiazide, and one arm was based on chlorthalidone. Keep in mind that the way they did this, though, they used different versions of all hat and counted them in the numbers. They had meta-analyses that were drug-adjusted and office blood pressure adjusted. So when you adjusted it, the meta-analysis was drug-adjusted, the risk reduction for chlorthalidone versus HCTZ for heart failure was 23. The percentage of risk reduction for all cardiovascular events, chlorthalidone versus HCTZ, was 21. When they adjusted this according to office blood pressures, the percentage of risk reduction for chlorthalidone versus HCTZ was 18%. So you can make an argument for the superiority of chlorthalidone. Now, in these trials, and remember there are other drugs in these trials as well, when the reduction in office blood pressure was identical in both arms, the increased risk for cardiovascular events was 19% higher in the HCTZ arm versus the non-diuretic arm. That's a problem. Then, for those of you who like numbers needed to treat, the number needed to treat in relation to hydrochlorothiazide to prevent one cardiovascular event every 5 years using chlorthalidone was 27. You can talk about what that 27 means, but let's think about this. We got a lot of hypertensives. We got a lot of them on diuretics. Got a lot of them on it for a lot of years. I think you can improve some people if you use this data. Now, this is the article that you can call HCTZ Strikes Back. So this just came out. And so if you think about it, one of the fears when you try to get up and give a big talk, well, we found one is you take a date in advance, and what you wanted to talk about, the guidelines haven't come out yet. The second real risk that you have is right before you try to get up to speak, some article comes out, and somebody who's more well-read than I is going to make mention of this, and I'm going to stand here looking dumber than I normally do. So this just came out in the annals. And so what this is they use propensity score matching. And so when I see that term, I think of two words, Nathan Holliday. So Nathan has to be able to explain things like this to me because propensity score matching seems a little odd. Now let's look at this. About 30,000 Canadian patients, all age 66 or older. So older folks, all in Canada, they do a good job of being able to keep up with their patients up there and to follow folks. So they matched up every one patient on chlorthalidone was matched up with up to 2 HCTZ treated patients. So they looked at important outcomes as you see there. However, what they also looked at in this was safety outcomes. So this is one set of data that really looked at hospitalizations for hypokalemia and hyponatremia. The way this was defined, they didn't really give how low was it. Were these hospitalizations for potassium of 2.3? These were just hospitalizations where the admitting diagnosis, where one of the admitting diagnoses were these. So, even though these are relatively small curves that come out, this is primary outcome. What you see is one curve, basically, because they're laying one on top of the other, no difference. But when you look at hospitalizations for hypokalemia and hyponatremia, the chlorthalidone group was hospitalized a great deal more. In fact, if you look at this, this is just another way of looking at it using a different set of numbers, trying to match up doses of hydrochlorothiazide against specific doses of chlorthalidone. It's just a different depiction of the data. So what you see is chlorthalidone patients are 3 times more likely to be hospitalized with hypokalemia, 1.7 times more likely to be hospitalized with hyponatremia. Now, the limits on this, fewer chlorthalidone patients were on an ACE or an ARB, and for those of us who believe that ACE inhibitors should be in the water supply, that's a problem. Also, chlorthalidone patients, more of them were on a beta blocker, probably because they were using a drug called tenoritic that has atenolol and chlorthalidone in combination. That's really the one drug that has chlorthalidone in combination with something until now. There is the latest and greatest, supposedly, of the ARBs, azilsartan, is being marketed in combination with chlorthalidone. So, we keep moving along. And so one of the other rules I figured was that if I put a picture of one kid in a talk and the other one found out she wasn't in there, I'd get in trouble. So we have to have both of my daughters in there. So we await the release of JNC VIII. New data continues to come out. Major studies are ongoing, including studies at this institution, including this one. This is one of the latest and greatest that's come out. It hasn't all the way been published. This came off Heartwire. So this is SPS3. There was a part of this study looked at aspirin and Plavix for those with lacunar stroke, but what I want to focus on is looking at blood pressure targets. So those with lacunar stroke in the previous 180 days ended up being randomized to a blood pressure target less than 130 or 130 to 149. Again, trying to drive down the targets a little bit there. So what you see is at entry, blood pressure is the same, number of blood pressure medicines the same. But when you get to the last visit, the lower target was on more meds, and they were on more thiazides, more ACEs and ARBs, and more beta blockers, but simply because they were trying to drive to a lower target. Now, if you look at this, the number of strokes in the study and the number and the percent of strokes per year was lower in the lower target group. Did not reach statistical significance, but there was a trend that was considered there. And so in that, you know, the question is, if you follow it out further, will you see more? I don't know. But there was a trend there. So you see some improvement or some decrease in strokes in the lower target. So there are a number of questions that we have left to answer, including, for any given patient, what should their goal blood pressure be? We can make the argument in a number of patient groups we're still not there. We also need to further elucidate the J-curve. Also, you know, long term, we need to figure out a couple of ways of treating hypertension. One is the use of renin profiling. For those of you who don't understand that, what it is you'll bring somebody in and you'll get a plasma renin activity level on them. New hypertensives and those that are uncontrolled. And you use that to dictate what your next choice of medicines are, whether to take meds away, whether to add meds to, and also what kind of med you're going to use to treat folks. Some of you guys have seen me do it. I will do it when I get in a bind and I've got somebody on way too many drugs for my taste and I just can't seem to get them to goal. And so it's using the Lara method, and you can Google that, and basically it's a very straightforward walk you through it. Even I can do it. Also, should we be using devices to treat hypertension? Somewhere in my email there's a set of slides that's talking about some new devices that are going to be really cool to try out and hopefully try out here. And to use these devices, can we do something better than just give people medications? And so that still needs to be answered. Also, for folks like me, how do we better educate our patients about hypertension? Because we still don't get a lot of them to go, and we still can't get a lot of them to take their meds. So the summary slide, the data supports giving at least one blood pressure medication at bedtime to patients with diabetes. In patients with CKD, blood pressure goals are set on the basis of their proteinuria. Dosing atenolol twice a day may decrease the risk of stroke seen in other trials. And remember, this was in the setting of patients with known coronary disease. And data is mixed on the better thiazide-like diuretic, chlorthalidone versus HCTZ. However, you can draw your conclusions there, and I ain't going to stop using chlorthalidone. So, with that, try to leave a little bit of time here for questions. I like using this in my slides.